We have the most exciting part. Dr. Nayak sir, I, I think he needs no introduction. The president of the Glaucoma Society of India will tell us glaucoma medical management algorithm. So I think invariably people have the maximum number of questions on this. So
Good afternoon, friends. So I'm thankful for giving me this opportunity to GS to Shipla and the AIOC sports. And one of the thing that I'm sure everyone must have noticed that when we see the prescription, sometimes we really feel pity for the patient, not for for anything else, because if the don't think medicines are just putting simple eye drops, because it affects a lot of things. It affects the quality of life, it costs money, and plus the side effects. So we come to this. Just in brief, I'll try to cover. So for medical management, first of all, establish a diagnosis, which very nicely covered by Dr. Manavdeep. Establish a good baseline IOP, because the comment that he made, that intraocular pressure, because the baseline, basically three baselines you have to create first, and four baselines. One is intraocular pressure, because with that you will judge the efficacy of your intervention. The second baseline you will be forming about the perimetry. The third baseline, now these days, because OCT structural tests are done, so on OCT, the whatever parameter you are seeing, and before that, the optic disc parameter. So these four parameters you have to form a proper baseline. Then once you have done that, set a target IOP, then initial therapy to attempt the lower IOP to your target. But remember that I will come in sometimes later, that don't just shoot the AK-47 right in the beginning. So everything just in one go. You have to go step by step, because it's not a malignant disease. So if you, in the process, if you take even 1 month or 2 months, it will not harm that much. As against this, when you will be putting a lot of medicines in that patient's eye, probably you will be doing more harm. And then follow up frequently, which is a must, because you have to explain lifelong follow up. Also look at the quality of life and avoid some mistakes. Establish diagnosis, I will not go in detail, because really covered in quite detail. Good baseline, again I told already that intraocular pressure also consider a CCT, and perimetry, OCT, and optic disc. But in because the follow up, when every visit you will be doing whatever is required at that visit, because perimetry, OCT you will not be repeating every time. So in that case, you have to also see that what is the purpose of doing this follow up and measuring that. So intraocular pressure will tell you, suppose you have you have added one medicine. So if that medicine is supposed to produce 25% reduction of IOP, whether it is producing 25% means efficacious in this patient or not, that will be judged by intraocular pressure. But intraocular pressure will not tell you whether whatever target pressure you have reached your target pressure also, but whether it was sufficient or not. So whether you have to bring it down still further, that will be, intraocular pressure will not tell you. That will be judged by the other parameters that you are following up, the perimetry, OCT, and disc evaluation. So these two follow up, or the different thing that you are going to examine every time, will give you different hint to you that what way you have to modify the treatment. Then set a target IOP. For this, means there are many formulas, so many things. So you have to just keep in mind, you have to set a target, and the target pressure should be your initial goal. And the target pressure is, the definition wise, that pressure which is supposed to stop the progression or reduce the progression to your desired level without affecting quality of life, or the means a reasonable affection of quality of life. But it is not a single figure. Means don't think that it is 21, 18, 19. It is a basically range. So in that range, of course, the The bottom one will be the most desirable, but it is not always easy to attain that. And with treatment, what you do, the normal curve of the means normally also there is always some decay of the nerve fiber layer, but that normal in glaucoma it becomes enhanced. If you see the curve which is going down, the yellow one, so wherever you initiate your treatment, your aim will be just to make it at least parallel to the normal aging process, if you can attain that. Not easy to attain that, so that you can maintain the useful vision for some long time. And these things are basic principles of target IOP. Higher the pressure, you can keep little high. If the longevity is more, then of course you have to keep little lower, because the patient has to survive for long and live for long. And if the pressure where if the advanced stage of glaucoma, probably you will be keeping much lower target pressure. But the target pressure you have to always keep on re-evaluating, because it's not that today whatever you have fixed is always remain the same. So you have to also change the target pressure whenever. But to attain the target pressure, the least amount of medication to achieve the therapeutic response is used. And because if you put, instead of one medicine, if you give 3 medicine, definitely it will produce more result, but whether it's really required or not. So in the beginning, if you start with 3 medicines, and usually I have seen prescriptions that they start one with combination and then one more medicine, because all those people, the representatives who come and meet the doctors, say, doctor, there is a new medicine, and I am surprised sometimes the 3rd and 4th line of medicine are started in the first go, which is not correct. So it has to be graded approach, and the target pressure will be different for different persons. And these are various rough guideline, like American Society says early stage 20%, 30%, and advanced stage 40%, and with additional risk factor you go on adding some more. Now the selection of drug, how will you, suppose you are thinking, because you have got 3 options. One is the medicine, second one is laser treatment, and third one is some surgery. So everyone, if it is angle closure glaucoma, definitely you will think of doing laser treatment first, but otherwise the medical treatment usually given at first trial. So with that, how do you select a drug? So always remember, there are certain drugs which are first line of drugs, there are certain drugs which are not first line. So you start with the first line of drugs, because that has got least side effects and maximum efficacy. So you have to select the medicine based on the patients, what type of patients you are dealing with, whether the target will be achieved or not, what is the efficacy, the compliance you have to consider, the safety of those drugs, and the persistence, and on top of it also affordability. Because Harsh will agree with me, when Xalatan drop was introduced in late 90s, that time in India the medicine was costing, no sir, late 90. Harsh,
It doesn't matter. I think that is irrelevant.
okay, that is irrelevant. So that time the price of the drug was 3 ml bottle, and it was costing 1800 rupees. So remember, 25 years back or 28 years back, 1800 had got how much value? So how many people, how many of us, even the doctors also could afford that type of high price?
Then we have to select the patient affordability. In which car he is coming. We were trained.
So that we have to do even today. There are people who can't even afford 300. So we have to
So
decide.
then for that you have to keep a video camera outside. So you see this patient got down from which car. So whatever you select means usually on those basis. So I prefer to give it, means unless there is some other compelling reason, I usually try to start only when just therapeutic trial in one, which everyone may not agree with that. And so give that medicine in one eye and then call it after some time. Some time is after a couple of days, and then see how much reduction of intraocular pressure has been achieved. If it is based on the response, you can decide whether you have to continue or you have to start on the other eye also, or whether you have to discontinue. The first line of medications are usually prostaglandin analogs and beta blockers. This is a huge list which I will not go in, but some points you should remember: that avoid beta blockers in asthma, heart attack, heart block and COPD. Avoid PGA in inflammatory glaucoma, history of herpetic keratitis, CME. Avoid topical CAI in poor endothelial status, and alpha-2 agonist in infants and patients using MAO inhibitors, and especially in old age also, because the patient old age they feel very sleepy and sometimes they can fall because of that. Follow up, I said these are the things that you will be following up, and also I told you the purpose of that, because that will your basic purpose is to maintain the function and maintain the structure. The quality of life we never consider, but quality of life also has to be considered, because the type of drug that you are using, the type of routine that the patient is having, the lifestyle the patient is having. And suppose a labor class and you tell them to put medicine 3 times or 4 times a day, 3 times a day, do you think the patient will be able to do that? So you have to consider the patient who is sitting in front of you. Also, always talk to the patient, because glaucoma is the patient cannot realize the benefit of treatment, because you will say, I am very happy your pressure is controlled, and I am very happy your glaucoma is controlled. When you say, doctor, I was seeing the same earlier, now also I am seeing the same, so what way it is different? So it's very difficult for them to get convinced unless you have spent time, and every visit you should spend time so that patient remains compliant. Otherwise you will say, every time I go, doctor is giving the same medicine, continue. So probably may not come also to you for follow-up. Because glaucoma is one of the major eye disease that causes blindness worldwide. Even more people have glaucoma without being blind or becoming blind during their lifetime. And there are various causes for quality of life, because one is the various things, because the vision, the field of vision, the anxiety that patient is having, the medicine that you are giving. So with the medicine, the use of medicine, plus the cost of the medicine. So all those things, it becomes, plus as I said, the professional lifestyle of that patient. So all this affects the quality of life. So you should consider. So that's why an individual approach that takes into consideration an individual patient's preferences according to his or her own risk philosophy is the best way to manage glaucoma, and therefore preserve a subjective optimum quality of life. Because why I said different type of personality, because some patient will say, doctor, what will happen? Suppose if I don't use medicine, what will happen? So for 5 years nothing will happen. Your correct answer will be that. Suppose if I use medicine, what will happen? For 15 years you will maintain your same vision, or you will be functional, absolutely perfect. So I said, doctor, bhul jao. मेरे को ये 5 साल तो अब क्यों? Every time, why should I keep on putting medicine and you are affecting my quality of life? So it's everyone's attitude is different, and I always used to give example. We all are doctors. We all know alcohol is bad for health, but you see in everyday parties, everyone expects a lot of alcohol to be served. So
are you sure about that statement? Are you sure about that statement?
Which one?
A very critical statement you are making. Please withdraw that.
अच्छा, चलिए withdraw कर लिया. जब chairman is telling me, then I have to withdraw. Okay, now this algorithm, if you follow, probably you will not be over treating any patient with medication. And this is the European Glaucoma Society guidelines, that they always start with monotherapy first. If it is effective on intra, because there can be 2 alternatives, either it is effective on IOP or maybe non-effective. If it is effective, then the next step will be to see whether you have achieved target IOP or not. If you have achieved, definitely continue and follow it up as you would like to. If it is effective, but target IOP is not achieved, not reached, then this is the time that you can add another medicine. So don't add otherwise, then you can add. The second option can be that target IOP is not, that medicine is not effective on that patient in reducing pressure. Then there is no point of continuing this medicine, and you change this medicine and try with other medicine. So like this, you will not be putting unnecessary medication to the patient's eye. And that's why if you start first go the combination medicine, then there are two problems will occur. One is that if one is effective, one is not effective, you will not come to know which one is acting, which is not acting. And if there is some side effect or there is some non-tolerance of that eye drop, you will not come to know again that which medicine out of the two is causing this problem. So if you go like this, probably you will be definitely doing some justice.
Will you wait out for the washout time? When you change the second medicine of second,
No, washout time, I don't know. My views are always that washout time, probably something wrongly it has come in clinical practice. Because washout time is for research purposes. Suppose you are giving one medicine and you are now changing that medicine. So in that case, the result, you want absolute result of that, the effect of that drop. That's why you will wait for the washout period, so that the effect of the previous drop is not there at all before you start the other drug. So that in there it is definitely, it has a lot of relevance. But in clinical practice, do you think washout time? Because if it is there, means today you have put medicine, 2 days later, it will be hardly any effect left over. So I don't think it is really important washout period for the clinical, in the clinical practice. Now, in spite of whatever you have done, in spite of all this, if you see that patients, in spite of intraocular pressure control, that if the field patient is still deteriorating, then you check diurnal variation, you check compliance, you check some systemic features, whether some other things which is causing this, or maybe dealing with something different, not only glaucoma. So, and if everything is ruled out, then you try to reduce the pressure further. And of course, some common avoidable mistakes you should try to avoid. So prescription writing is definitely important, and these days prescription writing was this is my very favorite slide, and probably I have kept this slide for last 10 years with me, and the doctor who has written name is hidden, so no one can recognize it. But in this there are beta block, if you see, there are 4 types of lubricant. Last 3, this and this. So 5 lubricants. Plus also lubricant in the same eye in the morning and Salatan in the evening. So what is the point in giving this type of dosing? And if this type of complex prescription, if you give it to the patient, and especially remember, glaucoma patients are old aged. If they have, and they must be having some other comorbidity. So how many tablets and how many other medication apart from this, who can follow from this audience even for a week like this? And I just follow my teacher, Professor L.P. Agrawal, always used to tell us, no medication is best medication, and least medication is the best alternative, and above all, do no harm. Now, this is some of the wrong prescription again, like I have seen writing abbreviations, patient don't understand this. So you have to, and plus also, if you have to give IOTM once, you will not be giving it at night. So incomplete instructions, abbreviations, wrong timing, and
Sir, 5 minutes.
yeah, 2 minutes mein khatam. 2 minutes, okay. Now gelatin eye drops, 1 drop in each eye twice daily. Sometimes I have seen even some doctors writing in 3 times a day.
old formula. Any tablet should be taken 3 times a day, like that. Old formula.
Now this Ganfort eye drops, some of the eye drops doesn't indicate, means it doesn't give any hint what are the constituents in this. So it's a very common prescription, Dorjox T, Ganfort, Dorjox T. So it means beta blockers are there in both. So these type of prescription we should always try to avoid. Combig and Travacom. Similarly, the same problem. So combine different drug with different mode of action. Do not combine drug from the same class of drug. So first combination should be from the different mode of actions. Thank you very much.